Welcome back. In the chapter of the Epidemiology of Communicable Diseases, today's session will be the part 3 of tuberculosis, in which we will begin with childhood TB. TB in the children will present between 10 to 20% of all the TB cases. So we see that the cases of TB in children are representing 10 to 20% of all the cases of TB. How much? Of all the cases, 10 to 20% of cases are represented by the children. The source is usually an adult. How do these children get affected with TB? The source of infection to the child will usually be an adult. Often it could be a family member who is having the sputum smear positive TB. Then we see the frequency of the childhood TB is given in a population depends upon the number of infectious cases. So the frequency of the childhood TB is dependable upon the number of infectious cases, the closeness of contact with the infectious case. So the frequency depends upon the infectious cases, the closeness of contact with the infectious case, and also the age of the child when he is exposed to tuberculosis. So, the age of the child and the age structure of the population is important here. The age of the child when exposed to TB, these will determine the frequency of the childhood TB in a given population. Is it clear? What did we understand about childhood TB? Childhood TB, it presents 10 to 20% of all the TB cases. First point. Second, childhood TB, what do we know? That the source of infection is an adult. Third, what did we see? The frequency of the TB depends upon the number of infectious cases, the closeness of contact with the infectious case. Thirdly, the age of the child. Is it clear? Childhood TB. Now we move further. The childhood TB is mainly due to failure in control of the TB in the adult. So when there is a failure in controlling the tuberculosis in an adult, it can result in childhood TB. Under 5 years age group presents the 20% of the TB. So in childhood TB, the 20% of the childhood TB is seen in the age group of less than 5 years. The commonest age of the TB is 1 to 4 years. Is it clear? The commonest age in which the TB is found is 1 to 4 years. Treatment during pregnancy. Now we are seeing the TB during pregnancy and what treatment has to be given during the pregnancy. Streptomycin can cause the permanent deafness in the baby. So, streptomycin is not indicated in cases of the tuberculosis in pregnancy. We are not giving streptomycin because the streptomycin is ototoxic to the fetus. So, it should not be used during pregnancy. Is it clear? Okay, so before initiating the treatment of tuberculosis, the women of the childbearing age, we have to ask them about the planned pregnancy, about the current pregnancy, and we have to counsel the patients appropriately. So, with the exception of the streptomycin, because it is the first line anti-TB drugs will be safer to use. Streptomycin should not be used because it is toxic to the fetus. It should not be used during the pregnancy. Whereas the first line anti-TB drugs will include isoniazid, rifampicin, pyrazinamide, ethambutol. They are safe to use. The second line drugs should not be used because they are tetragonic. What are the second line drugs we studied earlier? In the part 2, we have studied various second line drugs, out of which mentioned here are fluoroquinolones and ethionamide. Is it clear? The treatment during pregnancy, streptomycin not indicated. Second line drugs should not be used, whereas the first line drugs can be given. The first line drugs will include the rifampicin, isoniazid, pyrazinamide, ethambutol. Okay. most important is the vaccination part, that is the BCG vaccination. So this part 3 will comprise the entire topic about the BCG vaccination. So we see that ever since Koch discovered the Mycobacterium tuberculosis, there were several attempts were made to prepare a prophylactic vaccine against this TB, using either the attenuated or the killed tubercle bacilli. Is it clear? Koch discovered the tuberculosis, Mycobacterium tuberculosis. Ever since then, they wanted some prophylactic, some preventive against this TB. They wanted to use either the attenuated tubercle bacilli, or they are okay even with the killed tubercle bacilli. So BCG vaccination was introduced. So we see that Calmette and Guerin in 1919 discovered the Bacilli calmette-guerin. So the Bacilli calmette-guerin is the full form of BCG. So the BCG stands for the name Bacilli calmette-guerin. You can see Albert Calmette and Camille Guerin are the ones who discovered the BCG. So the BCG stands for Bacilli calmette and Guerin. Avirulent for man while retaining its capacity to induce an immune response. So the BCG vaccination has a recognition for inducing an immune response in the people. During 1921 to 1925, BCG vaccination was administered orally. So initially the BCG was given orally. During 1921 to 25, oral administration was done. The first human was vaccinated by the intradermal technique in the year 1927. So after 1927, the intradermal technique, first human was vaccinated using the intradermal technique in 1927. Then comes the recognition of the value of BCG came in the year 1948, when it was accepted by the tuberculosis workers from all over the world as a safe preventive measure. So when did they accept the BCG as a prophylactic, as a safe preventive measure? It was accepted all round the globe by the tuberculosis workers in the year 1948. Moving further to the aim. So let us just discuss more about the BCG vaccination. So the vaccine BCG is the only widely used live vaccine, live bacterial vaccine. So we see that the bacilli used for the vaccine productions are the descendants of the original Calmette strain of BCG. So what is the aim? The aim is to induce a benign artificial primary infection and by stimulating an acquired resistance. What is the aim of BCG vaccination? We want to induce an artificial primary infection in the being by stimulating an acquired resistance. Is it clear? Then we move further. The aim has to be clear. What is it? Inducing a primary infection, primary artificial infection, and also we see that by stimulating an acquired resistance. Moving further, vaccine BCG is the only widely used live bacterial vaccine. It consists of the living bacteria derived from the attenuated bovine strain of tubercle bacilli. In the previous slide, we saw the bovine strain. Bovine strains are those which are affecting the animals. So, the BCG vaccination is derived from an attenuated or killed bovine strain. Bovine strain, it is bovine strain of tubercle bacilli. World Health Organization has recommended the Danish 1331 strain for the production of BCG vaccination. So which strain is recommended by the government? That is Danish 1331 strain has been recommended by the World Health Organization for the production of the BCG vaccination. Okay. Types of vaccination. Two types of BCG vaccinations are used. We have liquid vaccination, which is the fresh form, and also have the freeze dried vaccination, which is a more stable form. Okay, this is the liquid form and this is the freeze dried form. Liquid vaccination is fresh and freeze dried vaccination is stable. BCG is stable for several weeks in tropical climate, and up to 1 year it is stable if it is kept away from the direct sunlight and it is stored in a cool environment. So what is the duration for which the BCG can be stable? Up to 1 year it can be stable if the required environmental conditions are met. What are the conditions? It has to be kept away from the direct sunlight, it has to be stored in a cool environment, preferably refrigerators at a temperature below 10 degrees Celsius. It is kept in a refrigerator below 10 degrees Celsius. Normal saline is recommended for diluent for reconstituting the vaccine. For reconstituting the vaccine, we are using the normal saline as a diluent for reconstituting the vaccine. Moving further to the dosage. For vaccination, the usual strength is 0.1 mg in 0.1 ml volume. So we saw it in the previous lecture that 0.1 mg was used in 0.1 ml volume. The dose to the newborn aged children is infants is below 4 weeks. Newborn aged below 4 weeks is 0.05 ml. For the newborn below 4 weeks, the dosage is 0.05 ml. Okay, so generally the dosage is 0.1 mg. Okay, in 0.1 ml volume. For the newborn less than 4 weeks, it is 0.05 ml. Okay, this is because the skin of the newborn is very thin and the intradermal injection with full dose, if we give a full dose of 0.1 ml, they might penetrate into the deeper tissues and give abscess formation, or regional axillary lymph nodes can get enlarged. Is it clear? Why do we give 0.05 ml rather than 0.1 ml? We are going with 0.05 ml because skin is very thin. It can enter into the deeper tissues leading to abscess formation and axillary glands enlargement. Moving further to the administration. Inject the vaccine intradermally using a tuberculin syringe. You can see the tuberculin syringe used here as recommended by the World Health Organization. It is injected intradermally using a tuberculin syringe. If injected subcutaneously, it can result in the development of an abscess. The site of infection is above the insertion of the deltoid. You can see here above the insertion of the deltoid, the site of injection is the near above the insertion of the deltoid. Moving further, what is the phenomena after the vaccination? So what happens after the vaccination? After 2 to 3 weeks, a papule develops at the site of the vaccination. You can see the papule here. A papule will develop at the site of the vaccination after 2 to 3 weeks. The papule increases slowly in the diameter about 4 to 8 mm in 5 weeks. Okay, in the first 2 to 3 weeks, a small papule is seen. Okay, and then the papule slowly starts to increase in the size in 5 weeks. Okay, the size is 4 to 8 mm in 5 weeks. Healing will occur within 6 to 12 weeks and a round scar is formed at the site of healing. Is it clear? Healing will occur within 6 to 12 weeks and round scar is formed. Moving further to the complications. Prolonged severe ulcerations. You can see the prolonged severe ulcerations. Suppurative lymphadenitis, osteomyelitis, and death can occur. Is it clear? The ulcerations, suppurative lymphadenitis, osteomyelitis, and death can also occur. Then comes revaccination. Even 80 years after the development of the vaccine, it is not known whether the booster dose is indicated or advisable. We are still not sure whether the booster dose is indicated or it is just advisable. We don't know. Even after the 80 years of after the development, we don't know whether the revaccination has to be done in the people or not. Moving further to the contraindications. The contraindications are patients who are having the generalized eczema or infective dermatosis and hypogammaglobulinemia to those with a history of deficient immunity. So, what is hypogammaglobulinemia? Is an immune system disorder in which not enough gamma globulins are produced. Here, not enough gamma globulins will be produced in the body. Is it clear? Not enough gamma globulins are produced, so it is hypogammaglobulinemia. So we know that serum proteins are albumin and globulin. We have globulins subtypes like alpha 1, alpha 2, beta, gamma. So the hypogammaglobulinemia. Gamma globulinemia, what are those? Serum proteins, albumin, globulin. Under globulins we have alpha, alpha 1, alpha 2, beta, and then gamma. Patient under immunosuppressant treatment and in pregnancy, it is contraindicated. The vaccine is not indicated in those who are immunosuppressed individuals, and also those who are taking treatment for immunosuppressant treatment and who are pregnant. Even in pregnancy, it is not indicated. Direct BCG vaccination, that is vaccination without a tuberculin test. We are providing a direct BCG vaccination without prior tuberculin test has been adopted as a national policy in many developing countries including India. The direct BCG vaccination without a prior tuberculin test is accepted. It permits a more rapid and complete coverage of the eligible population. By this, we have a more complete coverage of the eligible population while we are reducing the cost. No adverse effects have been reported. Even if BCG is given to tuberculin positive reactors, we do not have any adverse effects to be reported. So, it is safe. BCG, okay, then comes impact. BCG is less effective than the chemotherapy. So the BCG vaccination is comparatively less productive than the chemotherapy, than the drugs. Then we see the BCG vaccination and HIV infection. A single dose of the BCG vaccination should be given to all the healthy infants as soon as possible after birth. So we see a single dose of BCG vaccination is given to all the healthy infants as soon as possible after birth. We administer the BCG vaccination unless the child presents with symptomatic HIV infection. So why do we not give the BCG vaccination in HIV infected infants? HIV infected infants will have a higher risk of developing the disseminated BCG disease, which can turn out to be fatal. So, the HIV infected individual should not be given BCG vaccination because they can develop disseminated BCG disease. Moving further to the combined vaccination, BCG can be given at the same time as OPV. So, we see BCG vaccination can be given at the same time of OPV. DPT vaccine may also be given at the same time as BCG, but in different arm without reducing the immune responses or increasing the rate of complications. So the DPT vaccination can also be given. Okay, the DPT vaccination can also be given with the BCG vaccination, but in different arm so that we can reduce the so that we can without reducing the immune responses of both, without reducing the immune responses or increasing the rate of complications, and also without increasing the rate of complications, we can we can administer both DPT vaccination and BCG vaccination at the same time, BCG vaccination and oral polio vaccine at the same time. Moving further to chemoprophylaxis. Chemoprophylaxis is now termed as a preventive treatment. What is chemoprophylaxis? Chemoprophylaxis is nothing but a preventive treatment. The case against isonicotinic acid hydrazide chemoprophylaxis will rest upon the 3 points. So before directly going into it, see that chemoprophylaxis. What is chemoprophylaxis? It is a preventive treatment. Isonicotinic acid hydrazide, which is nothing but INH. It is also known as isoniazide. For 1 year or INH plus ethambutol for 9 months has been tried in the contact reactor. The case against the isoniazide chemoprophylaxis is resting upon 3 points. So there is a case against this chemoprophylaxis. So what did they do? They used isoniazide for 1 year, ethambutol for 9 months. They have been tried in the contact reactors. So, but there is a case against this chemoprophylaxis because of these 3 points. What are the 3 points we see? First, it is costly exercise. Okay, the cost is too high. It is a costly exercise. People can't afford isoniazide for 1 year and ethambutol for 9 months. So it is costly exercise. Secondly, it is not strikingly effective as well. Also, it has a small drug induced, it can also result in a small risk of drug induced hepatitis. So the chemoprophylaxis is therefore not a worthwhile exercise of tuberculosis control, especially in the developing countries like in India, where the resources are very limited. We cannot expect the chemoprophylaxis as a worthwhile exercise for controlling the TB, is all they want to say here. According to World Health Organization, mass treatment is not feasible. In this context, BCG vaccination gets priority over the chemoprophylaxis. Moving further to the drug resistance. All the drugs used in TB will produce resistance. Resistance can be of two types. It can be pre-treatment resistance or it could be an acquired resistance. What do you mean by pre-treatment resistance? It is the resistance which is shown by the bacteria in a patient who has not received the drug in question before. Pre-treatment, prior to the administration of the drug, he shows the resistance to the bacteria in a patient who has not received the drug. He shows resistance to the bacteria who has not received the drug. Acquired resistance, here the bacteria were sensitive to the drug at the start of the treatment, but later on they started to become resistant to that particular drug during the course of the treatment. Is it clear? Initially the bacteria were sensitive to the drug. Later on they became resistant to the drug during the course of the treatment. Moving further to the TB and HIV. Okay. HIV virus damages the body's natural defense, accelerates the speed at which the TB progresses from a harmful infection to the life-threatening condition. So what happens? What does the HIV do? HIV is accelerating the speed at which the TB progresses. Okay, TB might be progressing at this speed, but then once the patient is contraindicated along with the TB plus HIV, so this HIV will accelerate the speed at which the TB evolves, and it can turn the TB a life-threatening condition. HIV virus will damages the body's natural defense, reduces the immunity of the patient, and thereby the TB progresses. Moving further to the epidemiological aspect. The epidemiological aspect is the reactivation of the latent TB. People who are infected with both TB and HIV are 25 to 30 times more likely to develop TB than the people who are infected with TB alone. Is it clear? They have a chance of developing TB 25 to 35 times more chances. So, recurring infection. People having HIV who have been cured of TB may be at a more risk of developing TB again. Is it clear? First one was reactivation of a latent infection. The TB had come, then it is under a latent phase. The patient does not present with any signs and symptoms. It is latent. People who are infected with TB, both the TB and HIV are 25 to 30 times more likely to develop TB. So once the patient is infected with HIV and TB, they are more likely to develop TB than people who are just having TB. Just having TB are less likely, but those who are having both the TB and HIV, they are 25 to 30 times more likely to develop TB. Then comes recurring infection. People having HIV who have been cured of the TB may be at a more risk of developing TB again. In the past, a person had TB. Okay, let this imagine this person had TB in the past. He got cured of the TB. Now, after a variable period, he started developing with the HIV. So, once the HIV got developed, he has a higher chance of again developing TB. Recurring word itself indicates that again the TB might develop in the patient who have HIV. In the community, we need to educate the people that TB is curable and the people are no longer infectious after the first few weeks of the treatment. Is it clear? We have to educate the people in the community that after the few weeks of the treatment, the patient is no longer infectious, and also TB is curable condition. Moving further to the National Tuberculosis Program. The National Tuberculosis Program has been under operation since the year 1962. The long-term goal of the National Tuberculosis Program is to reduce the problem of the tuberculosis in the community sufficiently quickly to the level where it ceases to be a public health problem. Is it clear? What is our long-term goal? We want to reduce the problem of TB sufficiently to a level that it ceases to be a public health problem. Moving further to the revised National Tuberculosis Program, the Government of India, World Health Organization and World Bank together revived the National Tuberculosis Program in the year 1992. So we see the National Tuberculosis Program was in the year 1962 and the revised National Tuberculosis Program was in the year 1992. That was NTP in the year 62. Revised National Tuberculosis Program in the year 92. 62 and 92. 1962, 1992. So the main pillars of the revised strategy are achievement of not less than 85% cure rate among infectious cases of TB. They had to achieve not less than 85% cure rate among the infectious cases of TB through the short course chemotherapy. Involving the peripheral health functionaries. So the peripheral health functionaries like the village health guide, ASHA workers, Anganwadi workers. So involving the peripheral health functionaries, they wanted to achieve not less than 85% cure rates among the infectious cases of TB through the DOT strategy. Detecting 70% of the cases through quality sputum microscopy. First objective of the revised National Tuberculosis Program was a cure rate, achieving not less than 85% of the cure rate among the infectious cases with the help of the peripheral functionaries, and also detecting 70% of the estimated cases through quality sputum microscopy. And then they are involving even the non-governmental organizations, that is the NGOs, and the directly observed treatment short-term chemotherapy. We have have DOTS, a community-based TB treatment and care strategy. Directly above, treatment short course. So the DOTS strategy was a community-based TB treatment and a care strategy. Then we have Stop TB strategy. Stop TB strategy was launched by the World Health Organization in the year 2006. Is it clear? The National Tuberculosis Program was launched in the year 1962. Revised National Tuberculosis Program was launched in the year 1992. And then we have Stop TB strategy, which was launched in the year 2006. The core of the strategy was DOTS. Indicators used to measure the implementation and impact of TB control were, so they had certain indicators which will measure what was the impact of the TB control measure and the implementation and impact of the TB control. So what were the indicators? We have case detection, the treatment success, incidence, that is the number of new cases. Then the prevalence are the old plus new cases in the community, and also the death rate. So these were the indicators which used to measure the implementation and impact of the TB control. Thank you. With this we come to an end of the session. I hope the topic tuberculosis is clear. If you have any doubts, put them down in the comment section. And if you like the video, hit the like button and subscribe.